So, okay, let's start. As I said, we will do this at least once a month. So, but we will try to do even twice a month, but we will see. Next week, I will be for a number of meetings in California for long COVID meeting mainly. As I'm starting a collaboration with the National Institute of Health on long COVID, and unless there will be any news due to Trump administration, but we will see. But we are aiming to collaborate with the US as well. So I will be on another time zone, so expect maybe some delays from my responses. So if you have any question in the meantime, many people are joining, so I think we are ready to start. It was for the National Institute of Health of the United States of America, so the NIH, which has a recover long COVID program, and since a while also a long COVID pediatric program I am collaborating with, as we have more data than the United States so far. So we'll share some data with them for grants applications, and now I'm shifting, maybe next week, blood samples I've collected from my patients to Akiko Iwasaki in Yale. Don't know, maybe most of you have heard about her. She's done several studies on long COVID, and including some recent studies on autoantibodies in patients with long COVID, which when they were moved to and injected to mice, they led to the development of similar symptoms in mice as well, which is actually a groundbreaking discovery in my opinion. So she only did this experiment on adult studies, and with adult blood samples, and now she's looking for pediatric patients or young adults, and this is why I'm moving I'm sending samples which I store from my patients to Yale. So Bernard, let's start from the first question. I have a son that suffers brain fog and headaches. What success do you have in getting results resolving it? So, Bernard, when we talk about long COVID and chronic fatigue syndrome, it's not like we start one thing and we have success or not. So it's not like, as I always say, it's not like having pneumonia or an infection and we give an antibiotics and we have like 95% chances of recovery. Nowadays, we know that long COVID and CFS includes a large spectrum of patients, and the physiopathology may not be the same in every single different patient. So, with the current diagnostics we have so far, we don't know yet which patients will benefit more from a specific treatment. So we try a step-by-step approach. And so basically we try from the most simple to the most difficult approach based on the physiopathology of what we know so far. Brain fog and headaches, particularly brain fog, is the most difficult part to be managed, in my opinion. In terms of headaches, we have a lot of success with gabapentin. I can also say maybe 80 to 90% success with gabapentin. While for brain fog, we need more. We try first the immunoglobulins, the intravenous immunoglobulins. I'm having a great success with rapamycin as well. That the patient we discussed last time is still doing very great, and therefore, we start a journey, as I said, together. Most of the patients improve over time. Some we are close to declare them as solved, but most of them, trying one or multiple combination of therapies feels better. So it's difficult to provide a success rate. But I would say 50 to 70% of patients get better or significantly better compared to baseline. So let's see if there is any other question. I don't know if Bernard, this was clear. For Italian participants, if you have problems in writing messages in English, feel free to write in Italian and I will translate and will respond in English. My English is not that difficult to be understood by Italians as well. Okay, Fabio is starting with gabapentin. So, Fabio, let us know who prescribed it, and this is definitely a good point. You're starting with a very low dosage, lower than our pediatric patients, but it's okay from starting with cautious, very gradually, particularly if your prescribing physician is not very much experienced with that. In terms of therapeutical cannabis, no, I don't have experience with that yet because, let's not forget that I am a pediatrician. Okay, so I've started seeing young adults patients since a year to kind of trying to cover a gap in care for young adults, which are not followed by pediatricians anymore, but other doctors have way too many patients. So this is why I decided to start seeing young adults as well. But as for 99% of my practice, I work as a pediatrician. Some medications are even more difficult to be accessed in pediatric patients, and of course, therapeutical cannabis is one of them. So I don't even know how to access it honestly. So I have really zero experience on that. Okay. Nandini. Hi Danilo, let me read. I'm noticing continual vestibular headache for a while. It came as another new added symptom after my daughter made an attempt to go to school and then we stopped completely. She's back to homeschooling, but her vestibular pain is there. What is the dosage of gabapentin? So, as you know, Nandini, I don't like to give the dosage of gabapentin as since these medications need continuous monitoring and training by the neurologists. Even myself, I never prescribe gabapentin directly by myself, but I always consult and agree with the pediatric neurologists, which have more experience with this medication. This medication is traditionally uh, developed for as an anti-seizure medication, but now we know that it has much more and a broader effect on the central nervous systems, including pain control, pain pathways, but also mood pathways. So I don't suggest. We anyway start very low dosages twice or three times a day and gradually increase according to response, benefits, or lack of response. So it may require several adjustments. It's not most of the time is very well tolerated, but can have side effects. So I really strongly suggest to not do not use it as a self medication. I don't please try to let me understand better what you mean as vestibular pain, because this term is not completely, it's a bit unclear to me. Giuseppe, is it possible that this relationship with the NIH may open up funding opportunities for trials in your clinical practice and in your Italian EU-funded course on the horizon? So Giuseppe, this is a very good point. So first of all, have been just rejected 1 week ago from the European Research Council call for starting grants, which is even a bit less competitive call, and usually the first step is based on CV assessment, and actually my CV is very strong for my age peers, but still I didn't pass the first step. Unfortunately, there was a trial, a grant, a call for an application for a trial. This morning, I've submitted another trial for the Fondo for the Italian Fund for Science, and I applied for a low dose rapamycin trial. So that will be a big change in Italy, and I will open it if, in case I win the grant, even to European patients. So first of all, wish me luck. But if any of you has, and I don't know, any link within the Ministry of Health, or the Ministry of Research, you know what to do. So but I'm working on that. So I have submitted at least twice. Of course, the more we publish, the more chances we have to apply and probably to win. The problem with this course is that these conditions is really unknown in Italy or in Europe. So you need to be lucky to find reviewers that are at least a bit aware of this condition. So this was from Giuseppe. Tesi, another message. Almost all the children and adults I know with long COVID have also been diagnosed with POTS, postural orthostatic tachycardia syndrome. The beta blockers have been most effective in helping my child improve from symptoms such as brain fog, heart palpitation, and chest pains. Have you also seen any connection in your patients with long COVID and POTS? Definitely, yes. So POTS is the kind of baseline assessment I do in every long COVID patient. So the very first thing I do, I don't do anything else before assessing for POTS and treating for POTS. This is the very first step. Usually, particularly in children, I prefer ivabradine because it has less negative effects on mood, and it lowers less the baseline heart rate. But anyway, entirely agree. 100% of patients, they start with POTS and then we think about other steps. So in my experience, I would say 75% of patients with long COVID, both children and adults, have POTS as well. And we test with not only with a stent test, but also with a 24 hours electrocardiogram with heart rate variability. Message from Maria. Is it possible that mecfs or long COVID lead to muscle atrophy without it being correlated to lack of movement? I mean, situations in which your muscle starts shrinking and movement does improve it. Is there a way to reverse it? So, of course, it is now more than proven that all the muscular problems in patients with long COVID and CFS are not due to lack of movement, but they are due to an organic metabolic inflammatory diseases which particularly affect energy production and muscle metabolism, and therefore they lead to the muscular problems. Then the patient is not able to move, and in turn this further worsen the muscular problems. So definitely, yes, there is a correlation, which is not due to lack of movement, but to the disease itself. Is there a way to reverse it? I would say yes, because when we manage patients with one or multiple medical attempts, most of the time I'm not saying we can cure our patients, but 70-75% of the times our patients improve and are able to working again, then doing very little sport, yoga first. But I have patients that have been back to riding horses, to play golf and other sports. Not doing a marathon maybe, but yes, this can be improved. I think the longer patients wait because they remain undiagnosed and treated, and the more difficult can be to reverse everything. Green. Have you ever read about any potential immunosuppressive effects of rapamycin? Please Yeah, so rapamycin uh, is an immune suppressive medication historically. This was developed as an immune suppressant medication for kidney transplant recipients. So this was used to kind of delay your T cell immunity to avoid the immune reaction toward the transplanted kidney. But at low dosages, the immune suppressive effects are much less frequent and usually, and anyway, are not associated with major bacterial or viral infections as the full dosages of medication. So basically, patients can have really a normal life. Next Sunday, there is a blog post on rapamycin, a bit more detailed. And just yesterday, I met in the hospital my patient and my first patient of rapamycin, a young colleague, and she met myself with my boss, and she said, "Oh, Danilo, you saved my life." So I don't know if this is true, but she said this in front of my boss. So this is a very good point in the keeping this job, because when your boss recognizing this job, it's always important to have his or her support. So honestly, I'm not particularly worried about the immunosuppressive effects of low doses rapamycin. Of course, patients need to be a bit cautious, try to avoid major crowded uh, places. But for example, this patient traveled to San Francisco by plane under low dose rapamycin with my permission. So an Italian message from Massimiliano, which translates in English. I took valacyclovir, which is an antiviral medication for herpes and cytomegalovirus, and ivabradine, which is for POTS, and I moved from Bell 3040 to Bell 9095. Do you think this is just a chance or maybe a scientific reason? Yes, definitely there is a scientific reason. So this is not a chance or luck. There is a scientific reason. First of all, ivabradine, as I said, most patients just have POTS and only treating POTS, which is the easiest thing to treat, not 100% of time, but we already have guidelines for POTS. So only improving POTS, you improve heart rate, energetic consumption by your heart, peripheral body blood perfusion, including brain perfusion every time you are in the stand-up position. And therefore, this helps in terms of headache, energy, and many other symptoms. In terms of valacyclovir, if you are maybe a subtype of CFS that started after an herpes virus infection, you know that now there is much and growing interest toward viral persistence and this long-term chronic fatigue syndrome. So the rationale is there, of course, and it's a reasonable approach. Anandini, so the vestibular pain, it's behind her head on base or neck. I've been told it's vestibular headache. Okay, thanks for clarifying. Yes, but anyway, I will try honestly gabapentin in this case. Bernard, how can my Belgian child can be treated in your hospital by your team following your treatment, and will it be expensive? If yes, how much? So, your child can be treated in my hospital. Of course, you need to email this email address, which is international at policlinicogemelli.it, or you can just email me and I will put in our chat. So, what is the procedure? You email them, they email me, they are very rapid and responsive. They ask me, okay, Danilo, so what this child has to do in your hospital? And I do at least we always have a meeting first. So we decide your child has this, and this, and possibly this treatment. and they calculate a cost estimate. Those money don't go to me, of course, but they are used to pay the nurses, the hospital bed, the medications or the diagnostics. I only take the amount of money as any normal visit, so it's not a significant amount for me, but the costs are to cover everything. Usually it depends, can range from 2 to 4, 5 thousand per admission. But as I don't know the exact cost because those are not money coming to myself. So you will receive a cost estimate and you can accept that or not. Manu, many talk about Mestinon. If I'm not mistaken, there are a few trials studying it. What do you think? It always have to do with patient's blood. So I know there are trials ongoing, but this is not yet in the armamentarium of medications I've tried. It's still linked with with immunity, or in this case, this can be there are successful case reports. This is used for myasthenia gravis, and there are some reports that have suggested a connection with the acetylcholine link between neuronal cells, or the neuronal cells and the muscles. So yes, I think it's again a fascinating hypothesis. Usually, I'm going. I've not yet arrived there because I want to follow every time for every patient the same steps. Because otherwise, if everyone does a different thing, it's also difficult for us to understand what is better for each patient. And so that's why for now I suggest them to try only within a trial, or as a kind of a rescue approach. Massimiliano clarified he took valacyclovir for 18 months. Yes, the problem with this antivirus chronic suppressive treatment is that once you start, we don't know when to stop. So can be rapamycin dangerous with LLC stadium 0? Please, Fabio, can you clarify what is LLRC? Because I don't know if it's an acronym in Italian or in English. So, Jana, what is the youngest age you will try rapamycin? That is a key point. So, rapamycin is off-label in adults, is double off-labels in children. I would say I'm now discussing with a few pediatric patients where I'm not succeeding after other treatments. I would say at least when they kind of reach an adult-like weight, like 50, 60 kilograms, and have at least 14 to 15 years. So, and the patient would need to be very, very, very unwell. This is the type of pediatric patients I will consider. Ray Sullivan, rivastigmine is a gentle enzyme inhibitor, and so Ray Sullivan, I have having a lot of discussion with him, and he has a huge experience with that hydroxyurea, and we have prepared a specific blog post for hydroxyurea, because hydroxyurea has the potential to cover several immune-mediated and inflammatory pathways that are involved both in COVID, acute COVID, and long COVID, and also because it is used in other hematological conditions which share a lot of pathophysiological similarities compared with long COVID. The great advantage of hydroxyurea is that it is super cheap, and it is used in medical practice since decades. It's very safe, and it is also a lot used in very young children. I confess I was ignorant about this possible application, but Ray is helping me learning a lot about this new medication, this not new medication, but this new application of hydroxyurea. And I'm 100% sure that this is something we can try in the most in new cases, or where we are failing previous options. But so please follow my blog, because there is a blog post I wrote with Ray. Mostly Ray wrote it, which is extremely interesting for long COVID. And the rivastigmine, which is, yes, the mistinone, it's very much interesting. Manu, could you ask your colleague to take part to the next live chat? I'd like to know what were her symptoms now, how many years were suffering before rapamycin. So, she's a doctor. I'm not sure she's, I can ask, but I'm not sure she's happy to share, her face or whatever. She's been suffering for, like, I can say 2 years, but she only came to my house. She only talked to me after I wrote my book, actually. She was kind of shy to do so. She went to some other specialists with no success, but she had multiple symptoms. And but she was a doctor, so with her I felt more comfortable to say I will go all in with rapamycin without anything else. And that's why with her, she was a doctor, I could directly propose her, let's tackle the pathophysiology. I'm not saying this cannot be done with cannot be done with non-doctors. It's but it's also an issue about consent, understanding the risks and benefits of medications. But don't worry, because I am planning to start that medication with many of you. So Celeste said rapamycin, by modulating inflammation and cellular signaling, could help balance the autonomic nervous system, reducing excessive stress responses. Therefore, could it also help patients with sleep problems such as insomnia, non-restorative sleep, and fire symptom? Yes, if the pathophysiology is a underlying unbalanced inflammation, yes, I would definitely try. As I said, it is mostly well tolerated, and when there is some side effects, they are reversible by stopping the medication. So I will definitely consider in that case. Ray, again, I agree. The issue of systemic inflammation is key, and this definitely reinforces the approach of using hydroxyurea. Really, this is a fascinating option in my opinion. Okay, Fabio, you meant chronic lymphatic leukemia and rapamycin. I honestly don't know. So this is why I also usually treat children and young adults, because they are easier from this perspective in terms of other chronic comorbidities. So I should need to study, but most importantly to discuss with some expert in chronic lymphatic leukemia to see if there are any problems with rapamycin or not. Again, Ray, thank you for highlighting this. Hydroxyurea is FDA approved and safe in children as young as 9 months. Again, I said this before, and in my opinion, you will see many people here will be interested in maybe discussing this more. Theo, hello doctor, I'm a 23-year-old, sorry, Italian guy, and I want to start by thanking you for the amazing work you're doing. Thank you very much. This blog and your book. I don't want to annoy you by writing my whole story here, but I would like to ask how and where we can contact you to schedule a visit with you. So Theo, you just need to write me in the chat, and I will provide you a few options for an online meeting. In the online meeting, video meeting, we discuss your cases, we discuss what we can do or cannot do, if there is a possible diagnosis of long COVID or CFS, and what steps we can start in terms of diagnostic tests, but also therapeutic steps. So just drop me a message in the chat. I read and respond to every single message. Ray, thank to you because your input on hydroxyurea, I think, can open very interesting scenarios. So I think there is a last question from Niccolo. Hi, doctor. I hope you're well. Thank you. Wish you the same. What is the percentage of success to IVIG for severe bad bowel patients that did not respond, limited responses to most pharmacological treatments? So I'll say 50 to 70%. And again, where we are weak nowadays is that we don't know, we cannot predict before which are the patients who will respond. For example, now I have right now admitted a young patient, 18 years old from Sweden, for her second infusion of IVIG. So before this infusion, she was not attending school, 0% or 1 hour a week. She was not going out with friends, not doing sports, not making up because she was super tired, exhausted, the usual symptoms. After the IVIG, she went back to mostly all the activities. She wanted to come back from Sweden, and just today she was discharged because yesterday she finished the IVIG. So some patients have an impressive response. Some improves in pains, in resistance to some activities, and some do not respond at all. So this means that this will definitely be a treatment I would try. It is, in my opinion, it is very easy to be used, but the only problem is that they are a lot expensive. So most of the time they are not covered by the national health system, and patients have to pay them. But I still prefer to use them before rapamycin because rapamycin is less used compared with IVIG, and therefore I still think it's probably ethical and safer for the patient to try IVIG first and to use rapamycin only as a rescue therapy. Maybe in 1 or 2 years, as much we have more experience, which can change our idea and start with the rapamycin, which can be done with oral pills at home, and in case use IVIG as a rescue therapy. Hi, Christian from Vienna. Hope you're better. You're still better. Please let me know. Okay, so as I said, we usually try to do 30 minutes. So 30 minutes, are sustainable for everyone. And I know we could talk for hours, but 30 minutes are sustainable for everyone. And this will allow us to be repeated every month or twice a month. Low dose naltrexone as well, it can be used, but again, like 40-50% of patients improve. I don't have a lot of experience with that because in children this is very difficult to be used, and as a pediatrician, I feel more confident in using the medications I use the most, even in young adults. But I will have years in front of me, and I'm happy to starting new medications as well. Except Manu had no benefit at all from low dose naltrexone, so I would say 50% of improvements, but maybe less. Okay, see you next time. I think this meeting will be recorded and posted on our blog, so feel free to share with friends, parents, teachers, any workers can be related to these things, to these topics, and see you next time. Bye bye.